I'm Cheryl Bushnell. I'm one of the co-PIs of COMPASS, and today I'm going to talk about how to score the NIH stroke scale retrospectively, and this is to help us get scores for the patients that you've enrolled in COMPASS that had missing NIH stroke scale. So what we're going to do is go through and figure out how to extract the NIH stroke scale from the medical records for patients who have it missing. So the objectives is to describe how the NIH stroke scale scoring was done at a number of different hospitals in North Carolina. And I'll show you what we did in that particular study, which was done at Duke. And then I'll describe the algorithm in detail for how to score the NIH stroke scale retrospectively. And then I'll give you some patient examples and run through the algorithm 3 times so that you can get a feel for how this algorithm works for somebody with a very mild stroke, a medium-sized stroke, or a large stroke. So the history of the NIH stroke scale goes back to prior to the NIHSS TPA trial, and it was actually derived from 3 different stroke scales. It was a Canadian stroke scale, a British stroke scale, and the Cincinnati stroke scale. And so the developers assessed the test and retest reliability and inter-rater reliability, and they correlated this with stroke volumes on a CT scan. And they found that the new scale that they developed was sensitive to change over time, which was very important because stroke is a dynamic process. And they validated the scale among a variety of providers. And ultimately, this was what was used to measure the stroke severity in the NIHSS initial TPA trials. And so I'm showing you here is the agreement for the NIH stroke scale among different providers. And they had a neurologist, a neurology house officer, a neurology nurse clinician, and an emergency department nurse clinician. And you can see that the inter-rater agreement, which is this mean kappa score on the right, was pretty good because a score that is greater than about 0.6 means that you have pretty good to excellent agreement amongst the raters. And basically what they showed was that early testing and validation of the NIH stroke scale could be performed among nurses, which is really establishing the importance of training all personnel who are at the bedside. And then what I'm going to talk to you about in the next several slides is how we used the retrospective algorithm to score severity both with the NIH stroke scale and the Canadian neurological scale at Duke when I was during my stroke fellowship. And my fellow stroke fellow, Dean Johnston, and I put together this small study to assess the correlation between agreement between 2 different raters and also how many of the items were missing when you look at different hospital records. And so we actually used an academic hospital and 2 community hospitals in the state who were places where as stroke fellows we did clinics, and so they were gracious enough to send us de-identified records of representative ischemic stroke patients discharged from their hospitals. So the NIH stroke scale was scored according to the initial neurological exam, which was documented in the history and physical. And then Dr. Johnston and I both assigned the NIH stroke scale and the Canadian neurological scale retrospectively to those records. And then we assessed the agreement of the scores between the 2 of us. And so this is just showing you the median and the range of scores with the NIH stroke scale and the CNS. And the CNS actually is the opposite of the NIH stroke scale. Normal is 11.5, and then it goes down to 0, whereas you know the NIH stroke scale starts with 0 as normal and goes up to 40. So this is just showing you the range of severity that were found in the patients that we reviewed. And our ICC stands for interclass correlation. And so our agreement essentially with these different scales and on different patients was pretty good, especially at the academic medical center and also at the community hospital that had neurologists seeing the patients and often doing the history and physicals. Now, the second community hospital didn't typically have neurologists in-house, and so these are records that we were trying to assess agreement on very sparse documentation. So you can see that here circled in red, the correlation was moderate, if not poor, at the community hospital that did not have the neurology documentation for the initial stroke severity and the neurologic exam. And so that was really the NIH stroke scale that suffered the most from that, because the Canadian neurological scale is actually a slightly simpler scale, and the agreement was much better amongst the raters for those for the CNS at all three hospitals. So we had almost perfect agreement except for Community Hospital 2, where neurologists rarely documented the history and physical and the neuro exam. So one of the other things we did was document the number of missing items, and you can see the percent missing was highest at Community Hospital 2, shown in the darkest gray vertical bar. And this was true especially for level of consciousness commands, for visual fields, and for the face symmetry. So also you can see there's more missing across the entire set of items shown here in this slide. And then that was also true, very true for neglect. But you see that even the academic medical center patients did not commonly have neglect documented. So in summary, we had inter-observer agreement. It was a little bit higher for the CNS versus the NIH stroke scale, and that the NIH stroke scale items were missing at all hospitals, but somewhat less so at the academic hospital. And then the agreement for individual NIH stroke scale items was variable, but again, this is based on the difficulty of scoring when you have missing documentation. So the NIH stroke scale was scored in this particular small study using the retrospective algorithm that I'm going to talk to you about today. And Dr. Linda Williams, who is in Indiana, and her colleagues there developed the retrospective scale and algorithm that I'll be showing you. And this was published in 2000. And the next several slides are going to go through the table and the algorithm that is found in the paper. And as part of this webinar series, you will be given a copy of a document that will have this, all of these slides and the tables to help you as you go through your own patient charts. So just to go through the different items here, starting with level of consciousness A and alertness. So essentially all of the prospective coaching that happens to score the LOCA is the same both prospectively and retrospectively. And then you'll see that for LOCB, which is whether patients actually can answer orientation questions such as their age and the month. Obviously, if somebody says they're oriented ×3, the assumption there is that they would have answered both questions correctly, so that would be scored a 0. If they're less than oriented ×3, for example, many people may be alert and oriented to person and place, but not time. And so then that would translate to a score of 1 because they probably only answered one question correctly. They would be able to answer their age, but perhaps not the month. And then if the retrospective documents say that the patient is disoriented, or if they have a receptive deficit, in other words, they are unable to comprehend, and if their orientation is not reported at all, they're coded as disoriented, so that would be scored a 2. Going on to level of consciousness C, which is commands. Obviously, if they notate follows commands and there is no other documentation of a comprehensive comprehension or receptive deficit, then therefore that would be scored a 0. And then if there's any intermediate description, such as intermittently following commands or only following simple commands, with or without a receptive deficit, that would get a score of 1. And then for the document stating, quote, does not follow commands, end quote, with or without a receptive deficit, that would give them a score of 2. And then best gaze is essentially the same retrospectively versus prospectively. And so hopefully there would be some description in the document about forced deviation or gaze palsy that would help to score this retrospectively and in a similar manner as the prospective method. So visual fields, again, if they are documented, if it says fold a confrontation, then that would be scored a 0. And then hopefully there would be some documentation of either a partial or a complete hemianopia that would allow you to score this retrospectively. For facial palsy, basically it's just whatever is described in the record. If it says that there is mild facial weakness, then we would assume that that's minor and they would be scored a 1. If they have partial face droop and no qualifier, if the record does not say moderate or severe, then they would be scored a 2. And if they say complete paralysis and it's markedly or severely drooped, then that would be scored a 3. In the motor for both arms, left and right, basically we're using the motor score that's documented in the neuro exam, which goes from 0 to 5. 5 is normal strength. 4+ is nearly normal strength, and so this would be scored as 0 because the assumption is that with 4+ strength, the patient would be able to hold the arm up for 10 seconds without it drifting. And then if there's mild weakness, such as a score of 4 out of 5 on the weakness scale or on the strength scale, then that would be considered a 1, and the assumption is that it would be drifting down. And then if there is some effort against gravity but cannot get it to 45 or 90 degrees, that is equivalent to a motor score of 3 out of 5. If there's no effort against gravity, that is the definition of 2 out of 5. They can move alongside the bed but not lift it up off the bed. And then for a 4 would be no movement, which would be documented as a 0 or 1 out of 5. And then for the leg, the same thing. It's just that the limb is held at 45 degrees instead of 90 degrees in the arm. And, again, mild if they drift down before 5 seconds, a 3 if they have some effort against gravity, a 2 for no effort against gravity, or 0 or 1 for no movement. Limb ataxia is essentially the same. If they document ataxia in the arm and the leg, then obviously they'll be scored a 2 because that's present in 2 limbs. And then the sensory loss is essentially the same, and just again depends on the level of documentation in the record. But hopefully they say whether it's mild to moderate, that the patient can feel the sensation but knows it's different, or if it's total sensory loss. And then language can be tricky, but of course if there is no aphasia, if language is considered normal, then that's scored 0. If there is an expressive deficit and that is not qualified as severe, then that would be scored a 1. And that's similar to somebody who you're testing the aphasia pictures. They're able to maybe name 1 or 2 pictures. They can say some ideas, but they generally can comprehend. So this is in that mild aphasia range, and they would be scored 1. To get a score of 2, they would need to have an expressive aphasia plus a receptive deficit, or receptive aphasia only. So this would qualify as severe because all communication is limited in this situation. And then again, if they have global aphasia and they're mute, that would be scored a 3, and you would hope that someone would document that severe aphasia or the fact that they are mute or have global aphasia retrospectively in the records as well. Dysarthria, again, if it's normal, then it's scored 0. If it's qualified as mild or moderate, or if there's no qualifier, then you can score it a 1 from the medical record. And then if it is severe and the speech is nearly unintelligible, then that would be scored a 2. And of course, you have a score of 2 if the patient is mute as well. And then extinction and inattention would be exactly the same as what you see with the prospective scoring, that they would have more than one modality of hemi-inattention to be scored a 2, but if it was one modality, it would be scored 1. So the paper that I described with this algorithm was validated using 32 ischemic stroke patients. They scored prospectively and retrospectively, and their agreement was nearly perfect. But of course, these are all raters who are certified in NIH stroke scale scoring, but again, showing that they had excellent inter-rater reliability. So the next several slides, I'm going to give you some patient examples and give you a chance to review the algorithm and score this on your own, and I'll give you a few seconds to do that, and then we'll discuss what the different points are on the retrospective algorithm score. So the first patient is a middle-aged woman who had sudden onset of left-sided face tingling that progressed to her left arm. And on the medical record, her mental status was documented as alert and oriented ×3. She had normal speech and language. On cranial nerve testing, her visual fields were intact to confrontation. Pupils were normal, and she had full eye movements. Facial sensations showed that she had decreased light touch and pinprick in the left V2 and V3 distribution with no facial droop. And then on motor strength, she had 5 out of 5 throughout, except for 4+ out of 5 left grip. And then coordination was intact, and sensation showed a decrease in light touch in the left upper extremity, but no extinction. So in other words, no neglect. So what is this patient's retrospective NIH stroke scale? Well, this is a pretty easy one. The motor score is a little bit of a red herring. It was 4+ out of 5 with grip, but otherwise 5 out of 5. So we assume that this is going to be a 0 because even if grip was weak, you would probably not have drift if the proximal muscles were intact. She had decreased light touch and pinprick on the left face and left arm, but able to feel it, so this was scored a 1 for the sensory. So overall, her NIH stroke scale would be 1 based on this algorithm. So that one was a pretty easy one to start with. Number 2, a little more challenging. So this was a gentleman who had acute onset of left-sided weakness, and he was brought in with some speech that was mildly to moderately dysarthric, but his language was normal, and he was alert and oriented ×3. His visual fields were intact, eye movements were full, normal facial sensation, but he had a marked left lower face droop. He had drift in the left upper and lower extremity, and that was 5 out of 5 strength on the right. He had mild dysmetria with left finger to nose and moderate dysmetria with left heel to shin. And then sensation was intact with no evidence of extinction to double simultaneous stimulation. So we'll go through, I'll give you just a couple of seconds here to look at your algorithm and see what you think about scoring this particular patient. So going item by item, we have a 1 for dysarthria. We have a face droop that was marked, so we're calling that a 3. He had drift in his left arm, which is a 1, drift in the left leg, which is a 1. He had ataxia in the left arm and leg, which will give him a score of 2. And his total NIH stroke scale is 8. So this is, again, probably a subcortical stroke because he did not have evidence of any cortical signs, and a moderate severity with a stroke scale of 8. Now, this is the most challenging one, and I'll give you a little more time for this. So this is a 92-year-old gentleman who had onset of aphasia and right-sided weakness. So this is his mental status description. His eyes were open spontaneously, but he was arousable with minor stimulation. He attends to the examiner, but they were unable to test orientation secondary to aphasia. So that's really important because, as you know, if someone is completely aphasic, you score the B and C portion of LOC as abnormal. So on language, he was mute with expressive aphasia. Cranial nerves, he had bilateral blink to threat, so this is a gross assessment of his visual fields. His eye movements were full. He had grossly intact facial sensation, but he had a severe right facial droop. And then on motor testing, he had at least anti-gravity of the left upper extremity, but it was drift in the left lower. He had minimal movement of the right upper extremity and lower extremity, which was termed grossly 2 out of 5. And then he was unable to cooperate with formal testing for coordination, and he responded to light touch, but only withdrew to noxious stimuli in the right upper and lower extremity, so some asymmetry in sensation. So let's go through all of these items because this adds up to quite a bit. So first of all, he's not alert, so he gets a 1 for that. He's mute with aphasia, so he is scored 2 for each of those, and therefore he has a 4. He has a severe face droop, which is a 2. He had drift in the left upper extremity. He had some effort against gravity in the left lower extremity. His right arm was no effort against gravity. That was a 2 out of 5, so that is scored a 3. And then similar for the right leg. And then on sensory testing, there was mild to moderate sensory loss on the right. We knew that there was asymmetry. And of course, with aphasia, he was mute and gets a 3 for that. And because of being mute, he gets a 2 for dysarthria. And his total is 22. So I think that once you get used to some of these consistent patterns across the retrospective scoring, this really just gets easier and easier with practice. So the summary and take home is that this NIH stroke scale can be scored retrospectively. It's best done. I think we noticed a huge change once we have electronic medical records and we have standard neuro exam templates that makes the NIH stroke scale much, much easier to score. And so, you know, the study that I did with my fellow stroke fellow back in 2001 would be much easier if we did it today versus then, where everything was dictated and a lot of paper charts. But the retrospective algorithm is good, but not perfect, mainly because the ideal way of assessing this is to have the patient's stroke scale documented prospectively. But this is at least a solid way of getting the stroke severity documented when it was otherwise missing. The scoring takes some practice, as I mentioned. It's more challenging for patients with severe deficits. So I'm pleased to be able to share this algorithm with you, but if you have any questions at all, I would be more than happy to answer them via email or through the Central Compass office. Either Sylvia Coleman or Misha Sassine can help reach me and pass along any messages if you'd like to go through them, or you can contact me directly. So of course, I want to acknowledge PCORI for funding the Compass trial. Want to just make sure we acknowledge all of the leadership. I'm sure you all know Misha Sassine and Sarah Jones. And then obviously you probably know Sabina Gazelle, Sylvia Coleman, Lori Needham. And then you may not know Ralph D'Agostino and Matt Ciota, but they are key drivers of our analytic team and the data. They basically live with this data, and Sarah Jones included. And they will be the ones who will use those missing NIH stroke scales, and they are incredibly valuable for the overall integrity of the Compass trial. We have our steering committee here, and then we have photos of all of the people who've been involved with Compass, both stakeholders and our key investigators. So obviously, everybody on the webinar probably knows the study website, and the Twitter and email information is listed here. So thank you so much for listening, and again, I look forward to hearing from you. If you have any questions on how to score the NIH stroke scale retrospectively, please let me know. Thanks so much.